Greetings and welcome to our lecture on early intervention strategies for arthrogryposis. Thank you for joining us. I am Fran Guardo. I am the director of the Paley Orthopedic and Spine Institute's Rehabilitation Department, and I will be presenting with Nelda Posada, who is a very gifted occupational therapist and a splinting wizard. I want to give a little bit of background on our center. We were founded in 2009 by Dr. Paley. We were originally the Advanced Limb Lengthening Institute, and I was fortunate enough to come on board at that time and build our rehabilitation center from the ground up. So what is limb lengthening and why is it relevant to the arthrogrypotic population? Limb lengthening is just that. It is slowly lengthening a limb. It can be lengthening 2 to 3 centimeters, or it can be lengthening a limb over a lifetime all the way up to 18 centimeters. So in the process of doing that, it grows. A device is either fixed internally or externally on a limb. The bone in question is broken, and it is separated a millimeter a day until the maximum has been reached. This creates very, very tight tissue in the best of hands. And so what we learned as therapists dealing with patients who were undergoing limb lengthening is we learned how to deal with extremely tight tissue. And I think that set us up in a very unique way to deal with children with arthrogryposis. In 2015, Dr. David Feldman joined our team, and he was already establishing himself as a leader in the field of arthrogryposis. I think it's very unique that he joined our team, in which we have under one roof, we have an amazing rehabilitation department. We have serial casting, serial splinting that occurs in our department, and we work side by side with the doctors. So we're all under one roof. If they have a question, they can call us down. If we have a question, we can call them down. So it's really results in like a synergistic relationship and synergistic outcomes for our patients. So when he joined our center and we started working on the arthrogrypotic population, I believe that it affected or positively affected the outcome of both of our practices. Fast forward to 2020, and we now have 11 physicians and a much larger rehabilitation department. And I would say that we have a variety of brilliant people working under one roof. So it has really enhanced, I believe, all of our practices and our specialties, because we can bounce ideas off of each other and we can get input from some pretty great minds. So let's move on to our discussion about early intervention for arthrogryposis. We know that babies tend to be affected throughout their bodies. Their trunk, their spine, their upper and their lower extremities can all be affected, and often are. Many centers tend to advise parents and families to wait and see. Our strategy is to get them moving as early as possible, or to unlock them. And it is important, we feel, that we use a variety of strategies to do that. But we also want to do no harm. However, at our facility, we believe that doing nothing is actually harming them, because the earlier we get movement in these kids, the less surgical intervention we feel in the future. And also, the stronger they get, the quicker they get, the more they can explore their world, and the less debilitated they end up in the long run. Today's lecture is going to discuss some basic tenets of our philosophy and some basic principles that we use in treating this population. You'll see on this page, or this slide rather, 3 babies that you're going to see recur throughout. And they look like typical babies born with arthrogryposis. Some are affected in all 4 limbs and spine, some are affected in just upper extremities and spine, and others are affected in just lower extremities. So how do we unlock them? What do we do for these babies to help gain the movement? And we believe that the earlier that you get them, the easier it is to unlock them. We do so with physical therapy, occupational therapy, serial casting, serial splinting, bracing to hold corrections, and then movement, movement, movement. So what techniques do we use to achieve that early motion? Well, first of all, you have to have passive motion before there's going to be active motion. A typical baby that's born comes out kicking and screaming and moving their arms and moving their legs. And as we know, many of our little ones born with arthrogryposis have multiple stiff joints, and there are places that can't actively move. It varies child to child, but the joints that cannot move, if you begin early on moving for that child and progressively moving that child through range of motion, then we see the stiffness dissipate to some extent, and you get more motion throughout the joints. Obviously, it's going to be different based on each child because each child presents a little bit differently. So we gain progressive passive range of motion, then we go on to prolonged stretches, and prolonged stretches can mean a 30-second stretch, or it can be serial casting or serial splinting. Once you've achieved the maximum, then you brace, and braces can go on and off, interspersed with movement. Modalities that we use to facilitate tissue elongation include moist heat, ASTYM tools, which are a soft tissue tool, electrical stimulation to stimulate those muscles to start moving, Kinesiotape, light gait for early walking. The trunk and spine in these children can be normal. They can have scoliosis, they can have kyphosis, they can have contractures, stiffness, and many of these babies have torticollis. The first picture to the left is a child that we've treated, and she is presented here on tummy time before she came to us. And as you can see, the only thing touching with her tummy time is her chest, because her back is so tight and so incredibly tight that her hips are up in the air. She's in lordosis and she's stuck. The second picture that you'll see is that same baby that same day, and she's sitting in her car seat and she's looking off to the left, and she's in, you can't see well because she is covered with a blanket, but she's in a C curve sit. So her body is rotated and side flexed, and we see actually lots of babies that come to us in that posture. It's not fixed, but it is their movement pattern that is predominant. So we really want to open them up to move in a variety of ways, not just to one side all the time. So in the third picture, you see it is an ASTYM tool that I'm using, and the child is over my knee. We're trying to facilitate relaxation of those spinal muscles that are the dominant muscles in this child at that time. And then we go on to providing, in the fourth picture, torticollis stretches. So we look at the child, we look what's tight, we look what's weak, and then we begin to address the tight tissue by releasing and stretching, and the weak tissue by trying to facilitate. So moving on with the same child, we've got her in the first picture where she's side lying into a little bit of spinal flexion. So we've used myofascial techniques, I've used ASTYM, we've used stretching, we've used heat, we've used positioning and taught mom and dad stretching and positioning techniques to use at home. And then if you look to the middle picture, oh, by the way, you can notice she's also in Ponseti casts. So we're not just working on one thing before we move to the next. We use a kitchen sink method in which we address everything at once. And then on the, in the middle picture, we're still dealing with her torticollis and trying to help her rotate her head passively, because remember, you have to have passive before you can go on to active, and we're still trying to gain that passive motion so that she can accept both sides. And now we're facilitating, trying to get her to go to either side. So now you look at the third picture, and she has lots of kinesiotape on her. She still has casts on. We've got some tape on her belly because remember in the first slide, her chest was on the ground, her erector spinae, or her spinal extensors, were firing so aggressively, but the abdominal muscles were not. So originally, her hips were entirely off the ground in a prone position. So we're trying now to facilitate with the tape and through a variety of other techniques, contraction of those abdominal muscles, because we got some passive motion through her spine to allow better facilitation of those muscles. We want her to be able to go through the developmental sequence of movement at an early age so that she can develop as normally as possible, or as much mobility as possible. Here's another child that has some similarities with the first one that you saw, but also some very distinct differences. But we're going to talk right now about the spine, and you can see the same pattern in her as you saw in the first child. You see in the prone position that her chest is on the ground, but her back is so tight and firing, not opposed by the abdominal muscles, that she is chest to the ground, bottom entirely off the ground. And we can also see with this baby that her hip flexors and external rotation, or rather, and external rotators, and her knee flexors are so dominant. We don't even really know, as this is often the case with young babies, we don't know what muscles are there and what muscles aren't there. So we assume that we have to unlock first, and then if there are muscles there, perfect. Hopefully we can facilitate those to start moving. If there aren't muscles there, Dr. Feldman has some really unique approaches to muscle transfers and a variety of other surgical options. But if the soft tissue is too tight, they're going to require more intervention surgically. So we want to at least prepare them for the surgeries in the future if they have no muscles, but we're not giving up on them at this age. So we're going to create that passive motion and try to facilitate that active motion. So you see in photo 1, at the far left, you see the little one with the very tight spine, and then that's a pre-intervention, so she hasn't had any intervention from us. And the next one is also pre-intervention, just looking at the hips. We will address her hips later on, but when she came to us, parents were posting update photos, and you can see after a couple weeks on photo 3, they put a side-by-side photo of, actually that was more like a couple months, they put a side-by-side of before and after. And you can see a dramatic difference in this little one. On the one that's on the photo that's far to the right, you can see she's in a prone position. She has casts on that are now extending her knees, and her hips have been stretched daily, 3 times a day, by parents and by therapists. and she is in a much more functional position. So let's look at that little one throughout the process. If you look at the photo on the far left, she is prone over a towel and she's got her casts on. You can see that her hips are flexed and she has casts that are difficult to see in that picture, but you can see the crease in her lumbar spine or in her low back. So there's a crease there. Pardon me, there's a crease there. That's at the beginning. She's been maybe with us for 2 or 3 weeks at that point, and we have to also have a support under her abdomen to avoid hyperlordosis. So that's where we started. The middle picture shows us stretching those hips. Her hip flexors, as the medical professionals know, attach on the anterior portion of the spine and the pelvis, and they can pull the spine into that hyperlordosis or that sway back position. So we want to release through progressive stretching those hip flexors in order to give her some motion at that hip and also unlock that spine. And in the third photo, you can see that she is now accepting that prone position much better. You no longer see that need for that towel roll underneath her belly, and you can see that the crease is now gone, and she's still tight at the hip, but she's doing much, much better. So again, we've worked on creating that passive motion in order to establish more functional movement patterns. You can also see now that her torticollis is less prominent, she's able to work on prone on elbows and come up, and she's even able to look both directions.
Hello, my name is Nelda Posada, and I am an occupational therapist at the Paley Orthopedic and Spine Institute. Today I will discuss the characteristics and the occupational therapy interventions that we use for treating arthrogryposis. When it comes to the upper extremity, the patient presents with the inability to use their arms and hands. Characteristics associated with arthrogryposis at birth are excessive shoulder, internal rotation, elbow extension, forearm pronation, wrist flexion, indwelling thumbs, and stiff fingers. Therefore, the deficits presented with these patients are lack of shoulder external rotation, elbow flexion, wrist extension, forearm supination, and fine motor control of their fingers. Our initial treatment intervention is splinting the child to improve joint motion. We do several serial splinting to gain wrist extension, increase the web space, decrease ulnar deviation, increase finger extension and flexion. Through serial splinting, we focus on weight bearing and encourage passive range of motion and active range of motion. Also, the use of kinesiotaping and electrostimulation to facilitate neuromuscular contraction. The child is able to use her fingers and thumb to peel a banana, hold a cupcake in her hand, bring a toy to her mouth, hold a bowl with 2 hands, and even suck her thumb.
Hi, mamas. Press your button on your toy. You did it! Yes, you did. Good job. Come on, push it. Yay!
You captured Zone C. You have advantage. Zone B lost.
Good job. Good job.
You captured Zone A.
on. Get it. Come on, Lucy. Press it.
5 minutes. Plenty of time to fight.
Come on, baby.
Yay! You did it! Good job!
At this time, we have opened many new possibilities and opportunities for a child diagnosed with arthrogryposis. Through our interventions, the patient can strengthen their upper extremity and hand to allow functional play and self-feeding. Our optimal goal is to improve functional movement to increase the quality of life for the patient.
In the lower extremities, as you know, the hips can be normal, and some babies have normal hips that have arthrogryposis, but often the hips are flexed, abducted, and externally rotated. They can also be adducted or together and dislocated. So it's very important to have a physician look at the children first before you begin much treatment, to know what you're dealing with. Are the hips located? Are the hips dislocated? Also, they can be windswept. So one can be flexed and the other can be extended. One can be dislocated and the other can be located. Moving on down to the knees, sometimes you have extension contractures where the knees are straight or even hyperextended and dislocated. And sometimes the knees are stuck in flexion. And like I said, they can be located or dislocated. And it's important to know these things so that you know what you're dealing with and what you can safely do for this child. So I'm not advocating that you begin treatment without knowing these things. If you get a child that comes to you and you don't know, you need to refer out, but don't do nothing. You can do something. If you can address the hands first, or address the feet first, or teach the parent positioning, there's something that can be done right away. But again, you need a doctor to look at them so that you know what you're dealing with and where you can go. So the feet and ankles, you can have normal feet as we talked about, or you can have clubfoot, which is Talipes equinovarus, or you can have a vertical talus, which is the exact opposite of that, or you can have one of each. So we know there's a variety of ways that these children can present, and for each presentation, there's a specific set of stretches and manipulations. The babies in these 4 pictures are babies that all have clubfoot. We use the Ponseti method, and this lecture is not to go into the specific details of that. That's something that can be taught at a later time, and it's very well established in the literature. So we use the Ponseti method for manipulation and serial casting. It is something that we do within our department. We have a specially trained team that does the Ponseti manipulations and casting. And because we are physical therapists and we do deal with soft tissue, I think that we do a unique job of this. We spend extra time addressing the soft tissues and helping to release it prior to the casting, and obviously we're doing also the manipulations that Dr. Ponseti and the practitioners of Ponseti method have taught us. So these are 4 of the babies, and we will move on. When addressing the arthrogrypotic lower extremities, again, we talk about casting, and we want to address the feet first. So if the knees are flexed, you can do that, and you can leave the knees flexed and begin the casting of the feet. We use accelerated casts for arthrogrypotic babies for a couple reasons. One is that these kids tend to get really stiff, and the traditional Ponseti method is to leave the child in a cast for a week. Well, when we originally were doing that, what we found was they got very stiff, and you were dealing with more stretching than if you accelerated things. We also have families that come to us from far and wide, and in order to decrease the amount of time that they have to be away from their families and away from their homes, we accelerate the casts. So we do 2 cast changes, sometimes 3, but usually 2 cast changes per week. Each cast is on 3 to 4 days, and in between each cast change, we are making sure that we are stretching every joint that was casted, so that they're not becoming too stiff. Also, we're teaching hip stretches to address their specific hip stiffness to the parents, and the parents are doing those 3 to 5 times a day at home. So for babies that have club foot, we're using the modified Ponseti method, again, the accelerated Ponseti method, and I'm not going to go into great detail with this at this time. We also use for vertical talus the reverse Ponseti method, which is well documented by Dr. Dobbs. We also do the hip stretches we talked about 3 to 5 times a day, and hip straps are given as needed. So for the hips that are externally rotated and abducted, we don't want to leave them in that position, especially with heavy casts on them. So we bring a strap, a Velcro adduction and internal rotation strap, to help maintain a better position and slowly elongate those hip muscles. Continuing with the early intervention lower extremity strategies, there are some children that are stuck in extension, meaning their legs are stuck straight and they don't bend well. So we do want to know if those babies' knees are located or dislocated. The typical Ponseti casts the knee at 90 degrees. Well, if 90 degrees doesn't exist in that baby, you're going to have to try to begin flexing that knee to 90 degrees if it's safe, but you go bit by bit by bit. It's a serial cast. You do want to get some flexion there though, because it helps you maintain, or rather it helps you gain the proper foot position. But if they're dislocated, you're not going to be forcing that knee into flexion because it can actually harm the knee. These are things we'll teach later on in a more in-depth lecture. But so begin casting knees into extension once the feet are corrected. So once you've gained foot correction, and that may include tenotomy, it almost always does with an arthrogrypotic child. Once you've gained the correct foot position, then if the knee is stuck in flexion, if the baby came with stiff posterior knees, meaning they didn't extend, now you can begin serial casting to gain knee extension. So the casts continue to be every 2 times a week, and with many stretches in between casts. We may also do some heat, we may also do some ASTYM, a variety of techniques to help elongate that tissue that needs to be elongated. And once maximal correction of the knees is achieved, meaning we've gotten them as straight as we can, maybe we've plateaued for a couple casts and we know that we're not going to get any more. So is that typically a totally straight knee for these kids? It's often not. It's often accepting a little bit of stiffness still, because again, in the beginning slides we talked about do no harm. You do not want to force a joint that cannot go there, but you want to see what you can get reasonably in order to give that child the most movement that they can have and facilitate development of their opposing muscles. And once you've got that, then you want to splint. So the splint can come off and on, and they can begin moving and hopefully kicking and hopefully achieving some type of mobility. So this is a child that you saw earlier in the slides, but this child illustrates everything I want to talk about in lower extremities as well. If you look at her first picture, which is with one cast on and one cast off, the reason she has one cast off is because that foot was so incredibly tight when we applied that first cast. Her foot went dusky, and we had to remove it. So in teaching Mom how to stretch that, we realized that it was just the tightness of that foot, and when we actually elevated that first toe, that her foot became dusky. She had a crease that was so tight and fascia that was so stuck down that it literally was impeding her blood flow when you just gently stretched it out. So we taught Mom and Dad some stretches to do over the weekend. We happened to bring her in on a Friday, the first day, and the cast on the right stayed on, but they went home and they did some stretches on the left. So when they came back on Monday, that foot had improved enough that we could then apply a cast to that foot as well and begin the Ponseti manipulation and casting and not lose circulation. So you have to look at the child, look at what they present with, look at the entire child. You can also see that this child has some of the splints on that we use. So we're not just doing upper extremities and we're not just doing lower extremities. We are addressing everything all at once. So the middle photo of the same child, these are all three of the same child. We now have both legs casted. We have both legs or both arms splinted, and we also have that strap that we talk about. So her hips were very, very stuck in abduction, meaning out, and external rotation. And initially in the first visit, we couldn't bring knees together. So we taught parents those stretches of bringing knees together and bringing hips into better position, and then we reinforced that with the strap to elongate those muscles so that we can open her up a little bit. And now fast forward quite a while. This is the child, this sweet little girl, when she is now beginning to stand and pull up, and her feet are in a lovely position. She does use splints, but she doesn't use them all the time, and she's able to stand plantigrade, meaning foot flat, and she's, you'll see some videos of her later on. No spoiler alerts here.